Hello, this is Dr. James Camp from Lee College in Baytown, Texas, and this is my cardiology lecture, Putting It All Together to Blood Pressure. We're going to talk about what blood pressure is and how it's regulated. All right, first let's recall the three phases of the cardiac cycle. Phase 1 is what we refer to as atrial systole. This is where the atria are contracting and blood is flowing into the ventricles. The sound of this phase is nada because none of the valves are closing here. And the effect on the arteries is pretty much nothing. There is no blood flowing into the arteries or into the heart at this moment, so there's no effect on blood pressure. Phase 2 is what we call ventricular systole. Here, the ventricles are contracting and blood is flowing into the arteries. The sound of this phase is your classic lub sound from closing of the AV valves. And the effect on the arteries here is an increase in pressure. The heart is pumping pressurized blood into the arteries, so we're increasing arterial pressure. Phase 3 is called ventricular diastole. Here, the ventricles are relaxing and blood is flowing into the heart. Okay, the sound of this phase is your harder dup sound, giving you that lub dup of the heartbeat from closing of the semilunar valves. And the effect on the arteries here, as the arteries empty into the veins and the veins empty into the heart, is a decrease in pressure. Okay? So you can see that when we measure the blood pressure, we write down two numbers. The higher pressure in the arteries happens during ventricular systole. So we call that systolic pressure. The lower pressure in the arteries happens during ventricular diastole. So we call it diastolic pressure. Now, blood pressure is used up as it travels through the body, except in the elastic arteries, which is basically the aorta and the pulmonary trunk. So we want to measure the pressure in the closest major artery to the aorta that we can get to. That we can get to is important here. If you recall, the closest major artery to the aorta would be the subclavian artery, but we can't wrap a blood pressure cuff around someone's subclavian artery. The next major artery is the axillary artery, also hard to access with a blood pressure cuff. So the first really convenient major artery to the aorta is the brachial artery. And so the standard reference pressure, whenever we talk to, whenever you hear various blood pressure numbers given, somebody has 120 over 80 or 110 over 70 or anything like that, they're referring to the brachial artery pressure, not to the pressure exiting the heart, the aortic pressure. Okay, what do I mean when I say blood pressure is used up as it travels through the body? Well, as we discussed in class, pressure is used up as it drives fluid flow. So the further you travel along a pipe, the less the pressure is. And in fact, the narrower the pipe, the greater that effect is. So as we travel through the aorta, very wide pipe, It's got elastic walls. Very little change in blood pressure from the start of the aorta to the end of the aorta. But as we travel through the major arteries of the body, we start to see pressure being used up. The brachial artery would probably be somewhere around here, which means that someone whose actual aortic pressure was 120/80, their measured brachial artery pressure would be 110 over about 70. Okay, which is a fine number. 110/70 is quite healthy. But you just need to know that when you measure 110/70, you're measuring their brachial artery pressure and not the actual pressure coming out of their heart. The other thing you need to know is that if you go further along the arms, getting down to, say, measuring with one of those wrist cuffs, you're looking at a pressure somewhere around here. So you're now down to 100/65, say. Is that still a valid measurement? I suppose so, but you can't compare it to someone's, if someone has a pressure measured at their wrist with one of those wrist cuff devices of 120/80, they've actually got high blood pressure, because that is by definition a lower number than what you would get from the brachial artery, which is the reference pressure. Okay, pressure continues to drop as we go through the arterioles. Squeezing through all those capillaries uses up most of the rest of our pressure. And by the time we get to those veins that are driving blood back to the heart, we've lost 90% of the blood pressure. So veins obviously have more difficulty with blood flow, sustaining blood flow. There are two solutions that the body comes up with to this. One is to make the veins huge. Okay, veins are much wider in diameter than arteries, and that allows, if you have a trickle of blood flowing through a wide vein, it's still a good amount of blood trickling back to the heart. Also, a wide vein has lower resistance to blood flow, so that lower pressure is more effective. The other solution the body has to the problem of driving blood through the veins is that it adds in some extra pumps. Okay, this is what in engineering we would call stage pumps, pumps that are not the primary pump, but they add a little extra pressure just in time. So one of those pumps is called the respiratory pump, and it's shown on the left here. When the diaphragm contracts, it puts pressure on it compresses, squeezes all of the abdominal organs, and that puts pressure on the inferior vena cava, and that drives blood up to the heart. When the diaphragm relaxes, it puts pressure instead on the thoracic cavity organs, and that pressurizes the superior vena cava and drives blood toward the heart. So you have this up-down effect going back and forth between the diaphragm being contracted and the diaphragm being relaxed, and each way you're pumping some blood toward the heart. The other, a little more commonly known pumping mechanism is the skeletal muscle pump. Whenever you have a vein going through a skeletal muscle or between two skeletal muscles, when those muscles contract, they compress the vein. The blood can't go backwards because it hits the venous valves, but the blood can go forward to the heart. So we effectively kind of milk the blood up toward the heart every time we contract our blood vessels. And this is why it's one of the reasons that all of the fitness experts out there are telling people that they need to, even if they have a desk job, they need to stand up and walk around at least once an hour, is to maintain circulation through the veins of your, the deep veins of your arms and legs. Otherwise, you end up in a situation called deep vein thrombosis, where the stagnant blood in your veins starts to coagulate and produce blood clots that could later on in life be quite dangerous. This slide shows briefly how we measure blood pressure. The basic idea is that at systolic pressure, the arteries are stretched. At diastolic pressure, the elastic fibers in the arteries recoil them back down to a normal width. We can compress the artery with a blood pressure cuff, and if we compress the artery to a high pressure, say 160 for a normal patient, that's going to be higher than systolic pressure, and it's also going to be higher than diastolic pressure, much higher than diastolic pressure. In both cases, if you're pressing in on the artery harder than it's pressing back, you're going to collapse the artery. The artery is flattened and there's no flow through the artery, so you don't hear any sound of flowing. If you decrease the pressure on the blood pressure cuff to around the point where you're below systolic pressure, now you're pressing in with a little bit less force than the artery is pushing out on you, and the artery is able to open during the systolic phase of the heartbeat. So during each systole, you hear a whoosh of blood flowing through that artery. You continue decreasing the pressure in the blood pressure cuff until you're below diastolic. At this point, you're now pressing in less on the artery than it's pushing out on you, even at diastolic pressure. So now the artery is inflated and allows flow the entire time. So you no longer hear any sound at all. So what does this mean in practical terms? You put this blood pressure cuff on somebody, you drive the blood pressure up as high as you can until you don't hear any sound, and then you slowly bring it down, and the blood pressure reading where you hear the first sound is your systolic pressure, and the blood pressure reading where you hear the last sound, or where you no longer hear a sound, is your diastolic reading. Okay, so now I want to transition. We now know what those two blood pressure numbers mean and how blood pressure varies through the body. Now I want to talk about how blood pressure varies from moment to moment in our lives, how the body regulates blood pressure. Blood pressure is regulated by the sympathetic nervous system, and the sympathetic nervous system gets its instructions from the medulla and pons of the brain through a couple of centers called the cardiac, the cardioacceleratory, cardioinhibitory, and vasomotor centers. Okay. And they in turn get their information from a couple of cranial nerves that innervate important chemoreceptors in the body. So there are important chemoreceptors and baroreceptors. So a baroreceptor, a barometer measures pressure, so a baroreceptor is a pressure receptor. When the aorta or the carotid artery sense a higher than usual pressure, they send those pressure signals up through the vagus nerve or the glossopharyngeal nerve to the brainstem to regulate. When they sense a lower than normal blood pressure, they send fewer signals, and so the brain knows to respond to that. Okay. How does it respond? Well, there are signals that are sent through, sent back down through the vagus nerve that slow the heart rate. And there are signals sent through the sympathetic trunk, the sympathetic ganglia, some of which constrict certain blood vessels, dilate other blood vessels, and have the effect of speeding up the heart. Okay, so the vagus nerve is going to slow down the heart. That's going to decrease blood pressure a little bit. The sympathetic nerves are going to speed up the heart, increasing blood pressure a bit, and also have an effect on blood vessels. Okay, what are those effects? So the sympathetic, its effect on most vessels is to constrict those vessels. What does that do to blood pressure? Constricting a vessel increases its resistance to flow, also sort of squeezes down on the blood inside it. So that's going to be an increase to blood pressure. Sympathetic increases the heart rate and increases the force of contraction, both of which are also going to increase blood pressure. So our sympathetic nerves obviously have a positive effect, an increase on blood pressure. Parasympathetic has the effect of dilating most vessels. Okay, now you'll probably read in your textbook that the parasympathetic nervous system does not actually innervate your blood vessels. That's true, but when you're in parasympathetic mode, you're not in sympathetic mode. So when the blood vessels are not constricting, they will be dilated. So in effect, the parasympathetic nervous system dilates your blood vessels, and that decreases blood pressure. The parasympathetic system also decreases heart rate, and it has no major effect on the force of contraction. So what this does to the blood pressure is to decrease it. So again, all the parasympathetic side of your body will tend to decrease your blood pressure. Okay, so now let's talk about feedback loops and how the body responds to low and high blood pressure. Low blood pressure is arguably the more dangerous of the two. If you don't have a high enough blood pressure, then your blood won't circulate and you won't get enough oxygen to your tissues. So a low blood pressure, it gets more attention from the body than a high blood pressure does. If there's a short-term drop in blood pressure, the most immediate detector for that would be the baroreceptors that we just talked about in the carotid arteries and the aorta. If the baroreceptors decrease their signals, that indicates a low blood pressure. The brainstem will activate the sympathetic nervous system. Why the sympathetic nervous system? Because the sympathetic nervous system increases heart rate and heart force and constricts your blood vessels. And this has the effect of increasing blood pressure. And if it's just a short-term drop in blood pressure, that could fix the problem by itself. And eventually, blood pressure will return to normal and you won't need to keep an elevated heart rate or constricting your vessels. But what if this doesn't solve the problem? What if we have a long-term problem with low blood pressure? Not just a moment-to-moment problem, but one that's taking a while to solve. The kidneys will eventually notice a decrease in flow through the juxtaglomerular apparatus, and that will release the hormone renin. Renin activates angiotensin, which is always in your blood, but usually inactive. And angiotensin will activate a hormone called aldosterone. Aldosterone signals back to the kidney, telling it to retain sodium, and at the same time, angiotensin 2 is having an effect on the blood vessels themselves, constricting them even further. So while we squeeze down on the vessels, We're also retaining sodium. If you recall from osmosis, water is going to follow sodium, so we're retaining water in the blood vessels as well, and more blood is going to be, more blood volume is going to equal more blood pressure. So together, these have the effect of increasing blood pressure further, and maybe we solve the low blood pressure problem there before we go into low volume shock. Okay. What about the problem with high blood pressure? This is a problem, that's probably more common in America than low blood pressure, but your body is not trained to think of it as being as serious of a problem. Short term, the baroreceptors will increase their signals, so the brainstem will activate the parasympathetic nervous system. Why the parasympathetic nervous system? As you recall, PSNS will decrease the heart rate and lead to a dilation of the blood vessels. Pounding less hard on the blood in the heart and squeezing on it less in the vessels will lead to a decrease in blood pressure. And if we just had a short-term high blood pressure issue, that may be enough to fix it. But what if your blood pressure is high for a longer term period? Eventually, your atrial stretch receptors will increase. This leads to a secretion of atrial natriuretic peptide, another hormone. This hormone also goes to the kidneys, but it has the opposite effect of aldosterone. It tells the kidneys to excrete sodium, and with less sodium, we'll retain less water. With less water, we'll have less blood volume, and less blood volume will be at a lower pressure. So this has the same effect as a diuretic drug. It's going to lead to a lower blood volume and therefore lower blood pressure in the long term. Okay, summing this all up, there are two things that can lead to activation of the sympathetic side of blood regulation. A decrease in systemic blood pressure leads to a drop in signals from baroreceptors, or we could have an increase in body stress or demand, which tends to be a sympathetic activator. This results in an increase of sympathetic nervous system signals to the heart and blood vessels, tells the heart to increase the heart rate, also increase the force of contraction, and it tells blood vessels in most parts of the body to constrict. Okay, we actually dilate blood vessels going to the heart and the skeletal muscles so that we can get more blood flowing to the important organs during body stress. But most of the organs, most of the blood vessels in the body, the cutaneous blood vessels, the blood vessels to the visceral organs, they're all going to constrict, and that's going to lead to an increase in blood pressure. Okay. On the other side, an increase in systemic blood pressure would lead to a rise in the signals from baroreceptors, or we could just have a relaxation of body stress that puts us into our sort of rest and digest nervous system mode. This results in increase of parasympathetic nervous system signals to the heart and blood vessels. This tells the heart to decrease heart rate, contraction force returns to normal, and it tells blood vessels to more or less to dilate. Okay, so that's less resistance to flow and a refilling of the venous reserve. Net effect is going to be a decrease in blood pressure. And that concludes our discussion of blood pressure. Please stay tuned for my next video on the important topic of cardiac output.